Polyhydramnios is probably the biggest indicator of problems. Go to the next. So here's the same patient we already looked at. And this is the information we can get. The ultrasounds are fairly standardized in terms of interpretation. MRIs are in utero are totally there's no standardization, and we've tried to do that. It's just hard to get the numbers together to do it. You know, in like 40 patients, how can you really say? But there's no standardized way of looking at it. Go to the next. So that's what exit means, ex utero, intrapartum treatment procedure. This is the same patient here, in utero and after birth. This one on the right, a little bit of sclerotherapy, but a very big mass. Patient's mother sent me that ultrasound picture and said, "Can you do something with this?" Because a friend of mine, they're from Billings. Billings is over 1,000 miles from here. You know, it's interesting to think about. It's over 1,000 miles. So it's like it's basically like a 17-hour drive. And a lot of our Alaska people are, further. So it's interesting. It's a long way. And we go to the next. So this is kind of the decision tree that we've come up with. So you have prenatal evaluation, there's imaging, ultrasound, maybe MRI. If it's posterior, we don't mess with it. Posterior neck mass, regular delivery. Anterior neck mass or upper airway compression, laryngotracheal anomaly. So if there's a laryngotracheal anomaly, the lungs don't develop normally, they don't expand. Normally you can diagnose that on MR. Chaos syndrome is the term, like you have laryngeal atresia. So it's very characteristic. You can look it up in books. And then, they get counseling. And this is where I think what happens at Children's is the family, the patients refer to the prenatal clinic and they call over the OB people and the specialist that's would be involved with the care of the patient afterwards, and the ethicist actually. And we sit and talk about it. So one scenario we've had was a mother had 2 children, third pregnancy, very, looked like arthrogryposis kind of a situation, massive neck mass to polyhydramnios, 26 weeks gestation, 27 weeks gestation, so long time till term. We would not want to do an exit procedure on anybody under 34 weeks of age. We decided to do that. If the lungs are immature, we try to hold off. Because we feel like, why should we do something if we're just going to put them through almost an experimentation? It's just too much information. So this woman was very early on, was having preterm labor already. They were doing reduction amniocentesis, taking a lot of fluid off. She wanted more kids. So the issue was, if we go through this and do all this stuff, you could lose her uterus because the mass was so big. And so they elected to do comfort care only, and the patient died, after delivery.
Did she deliver preterm then?
Yeah. Versus trying to do all this manipulation to stave off the preterm labor. And I think as time has gone on, I haven't talked with maternal fetal medicine people about it. We should talk about it, but I think when something's really bad, you can't stop preterm labor. And so, like you guys weren't involved with one patient, but we recently had one patient. We had 2 big lymphatic malformations in the NICU for a while. And one patient, we'd seen the family, really good family, and we elected not to do anything. And the patient delivered, it was comfort care only. The NICU doc said, it's a miracle, I got the tube in. I saw some bubbles and put it in there, and it was in. But the baby died about 4 weeks later in the unit. And basically was really having trouble ventilating the patient. We tried everything. And there was a medicine we were going to try, but the baby was never healthy enough for us to use it. Because the medicine, I think, would have killed it anyway. Stuff called sirolimus. Anyway. So that's what happened. I just think it was never going to work, versus this one I showed, which was kind of a miraculous. The kid's done very well in many respects. So the prenatal counseling is an important step, I think. It really is the education process. And you sat there for like an hour, and then the mother says, well, is it going to be okay? You know, so you give them all this heavy stuff, you know, and then they say, is it going to be okay? And, you know, so it's really hard. It's hard on many levels for it. So if there were an absent laryngeal airway, then you'd go straight to the rigid bronchoscopy tray, right? Because there's no point of trying all the other little boxes there. And you could diagnose that with an MRI. Then you go to the exit procedure, airway management. Easy laryngeal visualization, just put the tube in. If it fails, then fiber optic. I think I'm going to change this based on our experience. Difficult laryngeal visualization. I don't think you can use a fiber optic, frankly. I think what we would do, and this is Charlie and Bosie over there, basically, you know, if we can't get it in, sometimes just taking the baby out and seeing if they breathe and put the tube in there is the best thing. Almost a blind intubation. I mean, you can see it, but you can see bubbles down there. There's no real identifiable laryngeal structures, really, other than this inlet.
No glide scope. Like
I think the glide scope's too big.
Too big enough, I know.
Yeah, remember you're talking, you know,
Yeah,
pretty
space,
small mouths.
yeah.
This last kid we had, the tongue was really thick and hard. You couldn't move it around. It was like, I don't know what was wrong with that tongue, but it was screwed up. I mean, you know, normally, I mean, think about a little baby's tongue. You know, you can put the finger in there and push it all around. You can stick your finger in the larynx through the mouth in a baby, you know, for goodness sake. You can include the glottis. You couldn't do that in this kid. There's no way. I mean, there was this whole massive bloody thing. So I don't know, you know, so you say this here, LMA, you know, we've thought about that. It's kind of too small of a space. And you know, you got to learn from the, you know, learn from the neonatologists. They just tube them, and it usually works. So it's worked for millions of babies. Why couldn't it work here?
So do you usually have a huddle before?
Absolutely.
And
So go to the next. Let's go to another couple slides here. I'll show you the setup. You see all the bodies. So that's the kind of the setup. So those are all the bodies. So everybody's there. We talk about everything we're going to do. Yeah.
And when it comes to leadership in the airway, just in the airway management part, not the rest. So how do you divide who goes first? What is usually plan A?
Oh, wait, I go first.
With your you know, the same thing that you use for suspension.
Yeah, same deal. Yeah.
And on the previous slide, it said laryngoscopy possibly with ultrasound guidance. How does ultrasound help you?
So you can put it on here and see the tube go in the
It doesn't
airway.
know it's in, basically.
Well, so it's a liquid environment. Remember, there's no air. So ultrasound works great in an aqueous environment. It won't work in where there's an air interface. So you can see it going in.
And
Sorry, go ahead.
did you actually try fiber optic, or that's just a theoretical?
We had it ready, yeah. I've done it with the rigid telescope. The last one we did, I listened to one of my partners, and it was stupid. I shouldn't have listened to him. And because I put the tube over one of our telescopes, and basically I know that I perforated into the mass. Because it's just a little baby, and it would have been better just to use the tube with or without a stylet. Probably just the tube, because it's soft, you know, and it bounces. The ones we've had trouble with were where the trachea is not going straight down. The mass is pushing it over, so that does you put it in the glottic inlet, and it doesn't advance very easily because the trachea is going like that, and there's no reflex in place to dilate the airway. You know, like you would have somebody trying to breathe in. You know, I think that actually helps put the tube in because you have the patient breathing in. And things dilate. The muscles are there to open it up. So it's probably just kind of collapsed a little bit. So that's been one of the problem things.
Any way to predict with the prenatal imaging which kid will be able to breathe on its own and which one?
I think so. So we've had several, as time, now I've been trying to review it just to look at it, but I think now we've gotten better at saying, you know, this is not survivable. you know, this is not going to go well. Like a teratoma in the midline, in the tongue, that sort of thing. We've had several, and they have, you know, we haven't tried to, the baby's been, you know, died, basically. So there's some things we can say for sure, this is not survivable. I think the ones that we have to do something to guard the airway is a term baby where it's bilateral and you can tell the tongue is pushed up. There's no pharynx, you know, it's occluding the pharynx, and there's polyacramnia, so you're going to have to do something there. For the ones that are on the side, I don't think you necessarily need to do anything. You know, like this kid that when I showed with the big like soap bubble thing on the ultrasound, you know, that child, we had a dickens of time getting that tube in because the trachea went over to one side. And it was not that, I think the tube was in, it was confirming that it was there. That was that second step, you know, auscultate. Couldn't necessarily do it. That was the problem. And we finally confirmed it was in when we basically separated the child from, you know, we thought it was in, we took it over to the bassinet and we're resuscitating, and I was talking to the father, and Charlie and the NICU people were there securing the tube, resuscitating the baby, working together, and everything's going good, and then somebody pops her, you know, comes out and says, "You gotta come in there right now," you know, kind of thing. And the tube had fallen out, even in that situation. But there was air, you know, you could see air movement, and they put it back in where they thought it was supposed to be.
Can you confirm replacement with fiber optic? Or
Yeah, you
systemic
could. Well,
fluid?
so this last one we did. So you could put the tube down there, and this patient, I don't think anybody here was, Agnes, did you ever? So this patient was a mess. Yeah, nobody was there. A lot of other anesthesiologists on this patient. But the patient died.
I think it's probably on pain.
Yeah, maybe, yeah,
Is it
you
like
probably
really
got,
recent?
yeah, recent, very recent.
Yeah.
But that patient, so we put the tube where we thought it should go. And this was the one where I used the rigid telescope. And then we looked down through the tube, so it was a 3.5 tube, through the tube with a fiber optic, and everybody could see it. And we didn't really see clear tracheal rings, so we didn't feel like we were there. And so after about an hour of doing that, the baby started to come out more, and we just said, forget it. And we took it over to the bassinet, and Bosie was able to get it in when he saw air movement. He put it kind of where we thought it was all along, but we couldn't confirm it. And then subsequently, and this is when the kid's tongue was screwed up. I mean, you know, so subsequently, we were able to change the tube and stuff by doing microlaryngoscopy. One of the fellows tried to do kind of a Seldinger thing to change the tube out. That just wasn't happening. It was too small or too big. The device that to put in there to like insufflate air was too big. It just wouldn't fit through the tube. So we could see it, you know, just take the tube out and put another one in. But there was no recognizable, you know, there was no epiglottis that I would say, oh yeah, that's epiglottis. I think I saw vocal cords, you know, even in that setting. Because it was all swollen and screwball.
How often is tracheostomy really an option in these kids?
So you know, when you do the extra procedure, you have about an hour. People have kept people on maternal fetal circulation for an hour. I hope I never have to do a trach. But you could. I think in this kid that I was talking about, it would be impossible. It's just crazy. And I think, like, you always think, well, the standard thing, like we were talking about yesterday, you know, rigid endoscopy from our sense, stick a bronch in there. That could be done, but I worry about tracheal rupture. You know, I mean, it's a very real possibility. And then, of course, you know, the patient's dead, basically. So, let's go to let's see if there's anything else on here. Yeah, so this is the same patient. And you can see that's kind of, he's a little bit even smaller than that now, partly as he's grown. Go to the next. And this is just stuff talking about, go to the next. So, the ultrasound, I've learned a lot about ultrasound. I mean, you know a lot about it too. And I think the thing in this environment, which is kind of interesting, is, you know, seeing the motion of normal anatomic structures. If you can get the ultrasound to like do a sagittal section of the face, you know, seeing the tongue moving out, see the baby swallowing is always reassuring to know that there's something going on there. I think, you know, the placental location is a big deal too, because that's delivery planning. So if the placenta is right down where you make your uterine incision, that's a problem. If it's in its normal position up high and posterior, then it's good. But that would, you know, that would affect the planning of the procedure, and even if it's doable. And that goes into the kind of counseling. Carotid involvement, you know, I think you could, you know, if something was really vascular, you could definitely tell. Thankfully, that's very rare. MRI, you know, I mentioned the lung anatomy in this chaos syndrome where there's laryngeal agenesis.